I understand that in addition to liver morbidity and mortality associated with NAFLD/NASH, there's an accumulating body of evidence that shows that cardiovascular risk is very high in these patients, and that in fact it's the driving factor for death in many of them.
Yes, you're right, and you're one of the few people who knows this. Unfortunately, no, seriously, it's not well known in throughout many circles of medicine. So yeah, that's great. So just as a backdrop, I do clinical research. That's my main thing now. Has been for the last several years, and a very large area of our research is in nonalcoholic steatohepatitis. So there are over 40 drugs in development, and so many drugs many mechanisms of action being looked at to treat NASH. And the reason that so many drugs are in development is that we don't have a drug that's been approved for NASH, and NASH is increasing in prevalence. 25% of our population, maybe a little more, has non-alcoholic fatty liver disease, and somewhere between 5 and 7% of our population has actual NASH. And NASH, unfortunately, can ultimately lead to cirrhosis or hepatocellular carcinoma. So NASH is a really bad thing, and yet it's prevalent. And NASH and NAFLD are two of the liver diseases that are expected to rise significantly over the next 5 to 10 years. NASH is overtaking all other causes of liver transplant. So cirrhosis from NASH is becoming the number one cause of liver transplant. So this is a really bad thing. When you look at the typical NASH patient, that person tends to be metabolically deranged, if you will. Central obesity, insulin resistance, high triglyceride, a real atherogenic dyslipidemia with high number of LDL particles or ApoB, low HDL. So this tends to be somebody who would say, well, this is an individual who is already at risk for cardiovascular disease. But when these other comorbidities have been controlled for in studies, it really is looking like there's something inherent in the NASH process that's leading to an increased risk of cardiovascular death. So, knowing that, you might say, well, I'm sure we have great guidelines about how to manage these NASH patients to avoid cardiovascular death. And the answer is no, we don't have those great guidelines. So that's something that's really missing. And most clinicians don't really look at NASH patients as cardiovascular patients, and they should. We've looked at things, studies have been done looking at, for example, a group of patients. This was done in South Korea, a group of patients who at baseline had calcium scores of 0, and then separating the NAFLD and the non-NAFLD patients based on ultrasound of the liver, and then following them for several years and seeing who developed the calcification. And the fatty liver ones developed much more calcification than the non-fatty liver ones. And coronary calcification is a great tool to assess cardiovascular risk. It's our best non-invasive tool to assess that. So that's very meaningful. So the important thing, the takeaway message here for primary care practitioners is that when you see a patient who may have fatty liver, you should look for it. Look for it either with an ultrasound of the liver, an MRI, FibroScan if that's available. Look for it. Look for the possibility of steatohepatitis. Look for the possibility with fibrosis. Understand that there are many clinical trials that are ongoing, and look around your vicinity to see whether you can get these patients in clinical trials, because that's a hope for them, both immediately and in the future. So do that. But probably more importantly is let the patients know you have a fatty liver, and this can lead to not just cirrhosis and hepatocellular carcinoma, which are bad enough, but also cardiovascular death, or arrhythmias, or cardiomyopathies. So those are also associated. So let the patient know that, and then try to activate the patient to improve. Improve means lose weight, manage the lipids properly, exercise, so drink less alcohol. So these are the things that we can do, but we need to activate everybody. The physicians need to be activated, and the patients need to be activated. And the only way we do that is by understand, as you pointed out before, by through knowledge, by understanding the risk and how to identify this, and then ultimately how to prevent the events from occurring.